Thank you so much. A very good evening on this last day of an exhaustive, enlightening 4 day of All India Ophthalmic Society's first ever virtual conference. I welcome all of you, uh, all the participants, and my co instructors, and the expert panel who is available here today. Um, we need to understand that why did we choose communication as an entire instruction course uh, for this conference. And I thank the AIOC Scientific Committee and Dr. Partha in particular to invite us to do this instruction course. We have to understand that majority of the patient satisfaction issues and medical errors are linked to poor communication. Our course will highlight the importance of empathy in optometrists and ophthalmologists, and we will also share innovative methods for effective communication adopted by successful practices across India. So, as we go forward, I will be introducing my co speakers and the panel also. And you can see this roadmap with fresh ideas. We are going to reach our goal, a goal of a satisfied team and a happy patient. What more can an ophthalmologist ask for? So, yes, I start this session by talking about the why, how, and what of effective communication in eye care. I would like to introduce myself. I'm Dr. Zamindar. I'm an NAVH assessor, and together, 27 of us healthcare professionals run 3 Zamindar eye hospitals in Bangalore. I do some pro bono work for adoption, and my hobbies are acting, poetry, and some amount of visual thinking. My key to success is if you try, you might. If you don't, you won't. Let's come to the why of why do we need effective communication. There is a paradigm shift in the practice of medicine. Gone are the days when the doctor was God. Now, the doctor is only a service provider. And this changes a lot of things. The first question we need to ask ourselves while I'm talking to you, please do reflect and see whether the communication at all levels is it enough in your organization? Do think about this. Well, and we need to understand that in today's world, a Google savvy patient has a lot of doubts, confusions, and is very well informed. If all these confusions are not clear, if there is fear, there is disappointment, there is a wrong information, or there are doubts, you will end up having a 2020 unhappy patient. So enhance the communication skills of your team. And through the course, I'm sure that you will pick up many important tips to go around, introspect, and then work through the year to enhance this very important area of healthcare, sadly, a little neglected. Why again? Ophthalmic surgery patients are typically elderly and communication becomes very, very important. They have concerns about how the rehabilitation will happen. A lot of elderly people now do not want to be dependent on their children and they want to know exactly how things will happen after surgery. Communication helps them alleviate all these fears and be confident in your care. How do we achieve effective communication? If we are through with the why, we come to the how. Importance of right attitude towards work and value of patients. This is something which is should become a part of your culture and an attitude which your staff has towards work. Is work a burden? Is patient a burden? If that is the attitude, then there is no amount of training, no amount of motivation is going to help. Your staff needs to be a satisfied, happy staff for them to understand that work is not burden and patient is definitely not burden. After that first bump is cleared, you are now ready to train them. And you as a leader or as an important part of the organization at all points have to acknowledge teamwork. Team is very, very important, and everybody in the team needs respect and everybody needs gratification for the work they do. So is communication as simple as soft skills? I think many times we've heard and you know attended sessions where a lot of stress is given on soft skills. Smile, nod, listen, do not interrupt, kneel, be a little more, you know, empathetic towards your patients. But how do you actually do that? Dr. Samia will be talking in a dedicated talk in empathy. Communication training. When did you last do a communication training in your hospital, or was it done ever in your so many years of practice? Please do think about it. I am very grateful for my team that here my senior doctors and staff is ready to experiment and learn the importance of body language in communication. So get in some external trainers if needed, but see that communication training becomes a part of your regular training at the hospital. Believe in the magic of communication. Does good communication really help, or it's just only about patient satisfaction? No, my friends, good communication also brings in diagnostic and treatment accuracy. It brings in patient compliance and brings in patient safety. So communication errors are the major cause. About 60% of medical errors in healthcare is because of communication errors. Only 3% of adverse incidents are reported. Imagine all the 97% of adverse events are just brushed under the carpet. Now, if we really dig out into every adverse event which happens in a hospital, you will be surprised that 60% of them are because of communication errors. The handing over, the Bermuda Triangle of healthcare, is the communication error. Handing over from one doctor to another doctor when you're referring a patient, or from one staff to another staff, your patient can suffer communication errors. And this is known as the Bermuda Triangle of healthcare. When you want to go home, wouldn't you want to go home a happy and a satisfied person? You want to go happy back home for your family? If there are reduced conflicts with staff, patients, and family with effective and better communication amidst your team, don't you think this will happen? 70% of legal cases, the cause is communication errors. So if you want to safeguard your practice from legal cases, there is a dedicated talk by Dr. Nazia where she'll be talking about documentation of critical communication in your hospital. And breach of confidentiality is a major cause for litigation in the West. There are areas where you are not supposed to talk about one patient in the presence of another patient, or in presence of staff who are not directly connected with the treatment of that patient. These are critical areas or challenging situation of communication with Dr. Katyayani will cover now. So what do you mean? What do I mean when I continuously say effective communication? There are many things which we mean by effective communication. I will just give you a few examples. Respond and never react. Your patient might emotionally react to a situation. He or she might be having some personal issues, or there has been such a long waiting time before the patient came in to you. Please respond but never react. Involve patient in decision making. This facilitates decision making, and they will not blame you for any wrong outcome if they were a part of the decision making team. So give them options, address their concerns, clarify their doubts, and let them be a part of the team which makes a decision about their treatment. At the end of this entire discussion, they might tell Dr. Saab, aap decide karo. You decide what is best. But you need to earn that, right? Before you impose a decision on the patient. Put yourself in their position. If you had mature cataract, if you had retinal detachment, even if you had a conjunctivitis, how would you feel? Adverse event, if there is any adverse event, which is bound to happen in any healthcare organization, please maintain the same line of communication. And if at all, if you have warmed up to the culture of standard operating procedures in your hospital, this is one area where you should definitely have standard operating procedure. What will you do when there is an adverse event? This is going to be the most important SOP in your organization. So, friends, if I have to tell you what is an ideal communication, it is much more than soft skills. It's about building trust with your staff, with your patients, with society in general. Transparency. Accept your limitations. You are not God, definitely. And see that informed decision making becomes a culture of your organization. Keep updating patients at different levels of their care, and control your own emotions. That is very important. A very difficult thing, but the most important thing is that respond but never react. I would like to take great pride in saying that all my efforts so far have been always supported by my great team, and any recognition award is due to me only because I have got a great team over here. And you will definitely hear a few of them right here. But the entire team has supported this workshop. A lot of research and brainstorming has gone to bring you this wonderful IC. I'm going to stop sharing my screen here, and I will welcome our next speaker for the day, Dr. Samia Basanth. She's a cornea specialist. She's a DNB and a fellow of cornea and external eye diseases from Minto Regional Eye Hospital. She has a keen interest in gardening. And over to you, Dr. Samia. We are very keen to listen to you. Role of empathy in optometrist and ophthalmologist in an eye care organization.
Thank you, Dr. Zamindar, for the excellent introduction. Good evening, everybody. I'll start sharing my screen.
Without fail, yes. I hope Dr. Gopal Raju has joined us now.
Is it visible, ma'am?
Very visible and very audible. Please go ahead.
Okay. The question here today is, do we practice empathy? I think it would be a big yes from everybody. Today's topic for me to cover is role of empathy for communication amidst optometrists, ophthalmologists, counselors in an ophthalm practice. The whole agenda of empathy, I would take you through what is empathy, why we should practice empathy, and how do we practice empathy. This is a spectrum of empathy which was adopted from NN Group, that is the Neil Norson Group, which is a computer affirmatory firm from United States. If we extrapolate this spectrum to our practice, we have pity at the bottom. Moving up, we have sympathy, we have empathy, and then compassion. Pity and sympathy require no effort, whereas empathy and to be compassionate requires a lot of effort. Pity, you just feel sorry for somebody, and empathy, they just feel for somebody. But whereas with empathy, they feel from the person's perspective. Compassion, driven by empathy, they do take some action and to help the situation or the person. The sociologists have recognized three different types of empathy: emotional, cognitive, and compassionate. Coming to emotional empathy, it's the ability to share a person's concern or pain. Cognitive empathy is the ability to share a person's suffering. Compassionate empathy, you understand the person's predicament and take necessary action to help them in that particular situation. It is vital or essential, especially in our practice, always to differentiate between empathy and sympathy because they have different clinical outcomes. Empathy is a cognitive entity, that is, it is the ability to acquire any factual knowledge that can be tested, whereas sympathy is an affective entity. What we mean by affective entity is it is driven by emotions. Most of the actions are driven by a person's emotion or his feelings. Empathy always has positive, optimal clinical outcome, whereas with sympathy, you have vicarious traumatization. By that we mean there is soul burning, or because there's excessive empathy which is being excised. There is always linear personal growth when we excise empathy in our practice, whereas with sympathy, there is compassion fatigue. Always when we are empathetic, we'll always feel there's a great deal of satisfaction in our career path, whereas with being sympathetic or sympathizing all along, we might have a career burnout. Empathy can be taught at various levels from children towards, going up even to medical students, whereas sympathy is not easily amenable to changes. What is empathy? The perspective of empathy, you feel what, you see the world through what the other person's perspective is. That is walking a mile in someone else's shoes. Feeling, you feel with the person, not the other way around. You don't feel sorry for that person. You truly, and in the situation which they are, the deep emotional status they are in, you try and understand. This is what is empathy. Why don't we practice empathy? Where do we lack? We feel threatened often, based on our own fears or our projections or any past, bitter experiences. It often shuts our ability to practice or empathy. Being judgmental, we have already decided that we are right and somebody else is wrong. Even this diminishes our capacity to be empathic. Fear, it's a natural human emotion which leads us to defending ourselves from any threats or being judgmental. Why should we practice empathy, and what are the benefits we reach by being empathic? It's a bi-directional thing. Not only the patient, even the physician reaps optimum amount of satisfaction when practicing empathy. The right-hand side shows what are the benefits reaped by a patient, and the left-hand side depicts what are the benefits reaped by a physician. We build a long-lasting relationship and trust with the patient, which makes us relate easily to the strangers, and we build a compassion. Where from the physician's perspective or the physician's point of view, it decreases negativity, that is all the negative spiraling. By practicing empathy, any anger or frustration can be negated by practicing empathy, which reduces stress in the work environment, making it more conducive and more pleasant. It enhances relationships between not only patients and the physician, even with the patient and his colleagues, the doctor and his colleagues, or the doctor and his subordinates. This is the patient interaction. I have depicted it in a pictorial way. When the patient parks and enters our reception, there are various touch points where the patient interacts with various people in the organization. First, they come to the reception desk, they register, giving all their data. Then probably there's a waiting time in the waiting area. They meet the optometrist. After the optometrist, they are sent to the physician or the ophthalmologist. After they have a consultation with an ophthalmologist, they're either, if they require a surgery, sent to the counselor, or if there's a glass prescription or a contact lens prescription, sent to the opticals. From the counselor, they move to the insurance if required, or to the account section where they pay their bills and there's an exit. This slide has a bearing. The empathy scale, which is plotted on the Y graph, physician has to exercise a lot of empathy. That is why it is on top. This has a bearing on my next slide, which shows a weighing balance, accounts, waiting area and parking. If somebody falters somewhere, it can be compensated by the physician, optometrist or counselor, or in the insurance area or the reception. Physician taking the onus, being at the top notch. Exercising empathy will always help us to flourish, or the institution flourishes really well. We always increase our footprints, and of course, it generates revenue. Then how do we improve our level of empathy? There are a few challenges and few consideration points. We challenge our preconceived notions based on the patient's socioeconomic background, or our biases based on anybody's ethnic, cultural backgrounds. Then we should always consider the other person's perspective or other person's point of view. And there's a scientific way where we can, see how we can assess sympathy. This is called the Jefferson scale of sympathy, which was formulated in Thomas Jefferson University in Australia from the Kimmel Medical College. It is a questionnaire which will be handed out. Initially, it was done to evaluate the empathy scale in medical students. Later on, it was extrapolated to physicians and other healthcare providers. There's a clear conceptualization of empathy, and here each respondent is given a score. It can be plotted on a histogram. A lot of statistics can be derived, including the mean, standard deviation, range, and more. And different quartiles can be calculated for the team. This is how a JSE survey or Jefferson School empathy survey looks like. There are 20 questionnaires and points are given, rating from 1 to 7. Strongly agree to disagree. They are computed, tabulated, and a total score can be given. And we can just assess the empathy scale in our team, not only the physicians, all our teammates, including the optometrist, the accounts person, or the front office desk. There are other ways to improve empathy. This is only one which I've listed here. Reading literary fiction. It always helps anybody to increase their empathy levels. It's like a role play. You put yourself in the person, the character, and that's how you train. Literature gives us a window to the inner thinking of other people. Not only reading literary fictions, even non-fictions like autobiographies and documentaries will increase your level of exercising empathy. I would like to quote Stephen Covey, who is the author of 7 Habits of Effective People. In empathic listening, you listen with your ears, but you also, and more importantly, listen with your eyes and heart. You listen for feeling, for meaning. You listen for behavior. You sense, you intuit, you feel. You have to open up to be influenced here by Stephen Covey. Any questions I think will be dealt with later. Thank you from Team Zamindars.
Thank you so much, Dr. Samia. It was a wonderful talk.
Thank you, ma'am.
Before I invite Dr. Katyayani, Dr. Samia, I think you can stop sharing your screen. Yes. And wonderful illustrations. Dr. Vibhuti was praising your illustrations. So I was telling him that there's a lot of research which has gone into all these talks, but thank you so much once again. And when you mentioned Stephen Covey, he also speaks about emotional bank accounts, that we have an emotional bank account with each other and with our patients also. So we have to be very clear that our withdrawals should not be more than our deposits. And that's very important. A happy and a satisfied team, which is born with empathy with each other, with enough emotional deposits, will work together, be happy, and will definitely result in happy patients. So now, without further ado, I would like to introduce Dr. Katyayani. She's our medical superintendent and a wonderful doctor. I have always praised her bedside manners, and now I'm shouting from the rooftops at All India Society, telling about that. Dr. Katyayani has done her MBBS and post-graduation from Mysore Medical College, and she is a part of our quality journey. We're very fortunate to have her with us. Over to you, Dr. Katyayani, for this very important topic about communication in challenging situation in an eye care hospital. Doctor, you can start sharing your screen.
Can you see my screen, ma'am?
No, we cannot see your screen.
Now?
We can see your screen now, yes. And we can hear you well. Go ahead.
Thank you, ma'am. Thank you. Good evening, everybody. Good evening, everyone. I'm Dr. Katyayani from Zamindar Microsurgical Eye Center, Bangalore. Today, my topic is enhanced communication in challenging situations in an eye hospital. What are challenging situations? These are situations in any eye hospital when there is a mismatch between the expectation, perception, and a communication between the patient and the doctor. And this could be caused by the doctor, the patient, or both. What are the factors that could cause these challenging situations? These could be related to the doctor, the patient, and the system itself. And this impacts the doctor, the patient, and the healthcare system. In the interest of time, I'll skip these 2 slides. Now, let us look at some simple tips on handling these difficult situations. First of all, plan your interaction well in advance. Write down your points before you communicate to the patient. This will help organize, filter, and refine your thoughts to communicate better. Use simple language and choose appropriate words that will not be perceived negatively or be offensive. Base your language on the questions put to you and on the cognitive ability of the patient. Be alert and watch out for warning signs like raised voices, uncharacteristic silence, or sarcastic remarks. Some could express negative body language like staring, invading personal space, some postures like clenched fist, jutting chin, or puffed out chest. Some threatening gestures are like finger pointing, foot stamping, pacing back and forth. Some patients may exhibit aggressive behavior, like kicking the furniture or hitting themselves. During these difficult times, focus highlighting solutions when there are disagreements. Include the caretaker in the conversation, especially if it involves bad news or the information being received is negative, unexpected, or difficult to understand. If the patient attendant is unavailable, check when they can be available for the discussion. If you have something important to talk and you feel the time isn't right, then inform the patient attendant. There's something I want to talk to you about. I know you're busy, but could we catch up in 15 minutes time probably? Approaching a patient in a busy, high stimulus area could hinder your communication. So make sure that your environment is correct, especially if you're going to ask questions of personal nature, then environment is particularly important. Also consider taking consent if many people are going to be present, especially if, when the discussion is happening. Example, students are going to be present. Listen to the patient. Listen to the patient for full understanding of his perspective. Allow them the opportunity to give you a clear picture of what they're trying to say. Positive body language and nonverbal communication. Put the patient at ease using nonverbal cues and show interest and concern. Show positive body language such as appropriate smiling, nodding, and eye contact. Get the eye contact right. Too prolonged could be seen as staring. Respect personal space. Standing too close could be seen as a threatening act. Now let us look at how we can enhance our communication skills. Use pictures and models to explain the patient's condition to educate. Involve the entire team to educate the patient. Involve the team in terms of explaining the drops to the patient, like glaucoma medication to the patient. The reception staff can pitch in. Give written information to supplement or reinforce your spoken word. Avoid information overload. Also, at the same time, give them access to further information and support in terms of important websites or links. Ask open-ended questions. Use what, why, when, where, and how. Summarize at the end. Let us see how there is scope for some self-improvement. Reflect and self-assess yourself. Feedback from patients and peers is invaluable. Improve your skills. Observe seniors or peers. While building rapport with the patient, you do not have only one chance. Not every interaction has to be perfect. Communication evolves. Be realistic with expectations and be patient and yet motivated to create small changes. Take help from colleagues, discuss with your seniors, and take up a training if it is required. Remember, while dealing with difficult situations, it is human to have feelings and emotions. Do not lose your temper or raise your voice or get angry, sarcastic, or provocative, or try to humiliate the aggressor. Take a deep breath, relax, and calm, and be neutral and respectful. Do not react and start disagreeing. Say no to unreasonable demands, but be prepared to manage any adverse reaction. Show warmth and empathy. Do not let a bad experience with one person affect your whole day or family life. Keep a perspective and a professional attitude. Now let us look at some scenarios. Communicating with patients with disabilities. While communicating with patients with disabilities, talk in the same way and with a normal tone of voice as you would talk to anyone else. Talk directly to the patient than to the accompanying person. Keep in mind their disability and their personal space. Do not push or move a person's wheelchair or grab a person's arm to help without asking first. When speaking to someone in a wheelchair, sit so that both of you are at the same eye level. While talking to patients with hearing loss, ask the patient how he prefers to communicate or eliminate or minimize background noise and distractions. If a patient is using a hearing aid, ensure it is on while talking to him. If speaking to a sign language interpreter, pause occasionally to allow the interpreter time to translate. Speak in normal tone without shouting. Ask the patient to repeat what you said to assess understanding. The next scenario would be communicating with elders. Avoid an overly familiar manner while talking to them in your first meeting. Avoid complex medical terms. Be prepared to repeat yourself and explain concepts in several different ways to make sure the message is understood. If the caregiver is present, remember not to ignore the patient. Keep the patient in the conversation. Although the patient may not understand a lot, it is important to show them respect and dignity. Offering them the extra time they need while communicating is dignity that should be above all else. Let us see how we can help communicate better with children. Trying to explain a difficult concept to a very young person in terms they understand and including the parents at the same time is a challenge. Explain the procedure to the child. This will reduce the anxiety and build their confidence. Use simple language and tailor your speech to meet their needs. Avoid negative words like hurt or sting. Offer lots of reassurance. Offer them a small reward for their resilience, bravery, and cooperation. Use positive, non-threatening tone of voice to show them that you mean no harm. Show through body language that you're listening to them carefully. While speaking to patients who speak a different language, learn some polite expressions and key phrases. Learn some key anatomical terms in their native language. Speak short, simple sentences that are easy to translate. Use pictures to explain. Example, how to instill eye drops. Show a picture of to them. Take help of the translator. If it's a family member, ensure they're present during all the visits. And consider learning a new language. While breaking bad news, keep in mind that you double check your facts. Prepare yourself and prepare the patient. Be compassionate about the patient. In the end, I would like to summarize with all these points. Use simple language always. Adapt. It's not a one size fits all approach. Some patients need time to open up, while some need to be interrupted to bring them back on track. Develop a positive body language. Remember, communication is not always with words. Teamwork. Involve the entire team in patient care and education, and the family members should be included in this too. This is the picture of back home ZMEC here, with all of us. Another point I would like to be pointing out is stay alert and watch out for warning signs. With this, I conclude by quoting these lines by the famous Persian poet Rumi. Raise your words, not voice. It is rain that grows flowers and not thunder. Thank you.
Thank you so much, Dr. Katyani, for this lovely presentation. And I just love what you ended with these thoughts of Rumi, my favorite poet. Raise your words, not voice. It is rain that grows flowers and not thunder. Uh, we go on to Dr. Nazia now. Dr. Nazia is a young and dynamic ophthalmic surgeon. She's done a MS and DNB from Hyderabad, and she's done her fellowship from Netradhama. She has presented national and international papers in conferences, and she was given this bursary grant to attend ESCRS in Vienna. So, Dr. Nazia is going to talk about something which is very, very important: documentation of critical communication. Of course, we are an NABH accredited eye hospital, and documentation is very important for NABH. But with or without NABH, there are certain critical communication which can be strengthened by documentation. So, I want you to be very attentive here and learn this. Remember, we believe only in God. Rest have to show documentation. Over to you, Dr. Nazia. Please share your screen.
Can you see my screen, ma'am?
Yes, yes, Dr. Nazia. Very visible, very audible. Go ahead.
First of all, I thank you for the wonderful introduction, ma'am. Good evening, and once again, a warm welcome to everyone. It is a pleasure and honor to share this virtual dais with many renowned ophthalmologists. I'm sure that everyone will agree with me when I say that excellence in medical documentation reflects and creates excellence in medical care. I'll be speaking more about this as my topic for today. Documentation of critical communication is only a reiteration of the same. We are all familiar with this phrase: what is not documented is not done. Documentation is an integral component of good professional practice and the delivery of quality healthcare. I want to highlight the fact that when we talk about critical communication, we are not only talking about communication between doctor and patient, we are also talking about communication between doctor, optometrist, patient, patient coordinator, surgeon, OT nurse, and all other hospital staff. I'm sure your minds are racing with the endless possibilities of person-to-person interactions, which form a part of critical communication. Regardless of the form of the records, whether it is electronic or paper, good clinical record keeping should enable continuity of care and should enhance communication between different healthcare professionals. These records are also valuable documents to audit the quality of healthcare services offered and can also be used for investigating serious incidents, patient complaints, and compensation cases. One must also keep in mind that these documents are part of legal records admissible in the court of law. This is one more important reason to maintain meticulous records. Like I said earlier, good record keeping is not only the job of the medical director or the doctors, but each person working in a healthcare organization has a role to play. Whenever or wherever appropriate, all members of the multidisciplinary team that are involved in a patient's care and in the smooth functioning of the healthcare organization should do their valuable bit. In the interest of time, I'll not be able to give an exhaustive list of situations where documentation of critical communication plays a crucial role, but I would like to discuss some case scenarios which we all may be familiar with. Here are some of the outpatient doctor-patient communications which need to be well documented for both the sake of the doctor and the patient. For patients diagnosed with glaucoma, it is important to explain to them about the progressive nature of the disease, need for the compliance to medication, and importance of regular follow-up. In case of patients with diabetes, they need to clearly understand the importance for strict glycemic control. The importance of early intervention to prevent worsening must be explained to the patients with age-related macular degeneration. They also need to be compliant with the follow-up schedule. The needs and expectations of patients due to undergo cataract surgery should be considered while explaining the procedure to them. The visual prognosis and complicated cases must be communicated in clear terms. All this should be properly documented. And it goes without saying that documentation of each of these issues will play a vital role in ensuring that your patients are happy and that you get a good night's sleep. These are some of the examples of critical communication with the patient that we maintain at our hospital. They may seem trivial at a cursory glance, but can make a huge difference in the well-being of our patients. We have made bilingual seals stressing the importance of continuing anti-glaucoma medications till further notice and using steroid eye drops only for the period indicated. These seals were born out of situations where we wished we had communicated to our patients better. In case of argumentative patients, trying to imply it is our fault that some untoward incident had happened, these can be used to transform the same patient into an apologetic one. We also make it a point to mention drug allergies on the patient's file and in our software. When we started this practice, we found that so many of our older patients on subsequent visits had known drug allergies, which we were not aware of, just because we had never asked till then. Now let's move on to communication in the case of patients scheduled to undergo cataract surgery. This is of vital importance in all our practices. These can be categorized into pre, intra, and post-operative. Let us start with pre-operative communication. As you can see, each of the items mentioned in the individual boxes is an important piece of information to all members participating in the surgical process. One such example is that the patient is on medication for benign prostatic hypertrophy, and this has to be communicated to the surgeon so that he or she is prepared for a floppy iris during the surgery. These are some of the forms which we count on to ensure there are no hiccups. These may be tailor-made to each of your practices. Now, we look at the intraoperative stage. Again, there are various parameters, none of which can be overlooked. We practice a timeout before starting the case where we specify the name of the patient, eye to be operated, intraocular lens power, and plan of the surgery. There was an incident where the surgeon remembered that IOL power mentioned during the timeout was not the same as the one mentioned when the IOL package was opened. The OT assistant usually calls out the intraocular lens power before opening it, and this is verified by the anesthetist. Now, let's move on to the post-operative stage. Extra chair time spent in explaining each of these will go a long way in ensuring you have a happy and a satisfied patient. This is usually done at our center by our counselor. Here's a quick glance at one of our checklists and our post-op medication list with timings and dates. Let us quickly move on to critical communication with the team. Our equipments are an important part of our arsenal. There are times when we have struggled because there is a loose contact in our slip clamp wiring or some big problem which our in-house maintenance person is unable to address. This is where the breakdown register comes into the picture. The person who first detects the problem notes down the same in this register. This information is conveyed at our center to our center head, who further communicates with the concerned company official to handle the problem. If the said instrument is critical and has no backup, like say the Humphrey field analyzer, then turnaround time has to be short so that work doesn't suffer. Maintenance of incidents or adverse event register is important to handle mismatch in communication. For example, if staff has instilled wrong eye drop or eye drop which the patient is allergic to, it leads to adverse effects. So this can be prevented by root cause analysis, preventive and corrective action, and communicating to the team so that this will be avoided in future. To have a better communication with other specialty doctors, we maintain a record of patients referred to them. Telephonic call is made to the doctor and explained detailedly regarding the patient, and referral letter is handed over as a part of documentation. So this helps the doctor to understand better about the patient. Along with this, even a SMS is sent to the specialist about the diagnosis and advice. So to conclude, the palest ink is better than the strongest memory. So don't forget to document. So today I thank you from all of our Zamindar team.
Thank you so much, Dr. Nazia. And yes, indeed, the palest ink is better than the strongest memory. So very, very thank you for that wonderful presentation. And that brings us to an end of all the didactic talks on communication. And we are here with this expert panel of doctors, very senior, experienced doctors from across our wonderful country. We have shared whatever we had to share from Zamindar's Eye Hospital in the spirit of die empty. And now over to you, very talented senior doctors, to tell us. I would like to now take the privilege to introduce this expert panel. Dr. Gopal Raju, for some reason, couldn't join us today, but nevertheless, we have Dr. Malai Chaturvedi. Dr. Malai is a senior ophthalmologist from Kanpur. He is, he's the immediate past secretary of UPSOS and an MC member. He's been given the prestigious MP Mehere Oration last year, a reviewer, evaluator, done more than 100 presentations. Welcome, Dr. Malai Chaturvedi.
Good evening, ma'am.
Good evening, Dr. Malai. Good to have you here. Next, we go to Dr. Bibhuti Bhushan. Dr. Bibhuti is from Jamshedpur, and he is a vitreoretina surgeon from Shankar Netralaya, Chennai. He's the director of Vishnu Netralaya, and he's multi-talented. I'm sure most of you must have seen him performing at the cultural event. So welcome, Dr. Bibhuti. Yes, we have Dr. Anurag Mishra. Dr. Anurag Mishra is from Cuttack. He's a very tech-savvy ophthalmologist, and he's a fitness freak. He is the director of the Radha Raman Hospital, and he has done 2 long-term fellowships. So he is a fellow of IOL and anterior segment and fellow pediatric ophthalmology in strabismus. Welcome, Dr. Anurag Mishra.
Thank you, ma'am.
Dr. Sarvesh Tiwari is from Mumbai, our financial capital. Doctor is an alumni of the Arvind Eye Hospital and is a VR consultant at the KBH Bachu Ali Hospital, Parel, Mumbai, also associated with the Hiranandani Hospital, Mumbai, and honorary consultant at MGM Hospital, New Bombay. Welcome, Dr. Sarvesh. We have, last but not the least, Dr. Mohak Amit Kumar Shah from Ahmedabad, Marupan City che Ahmedabad. MS Cure Specs Eye Care Laser Private Limited, a gold medalist in MBBS and MS, and he's presently the executive secretary of the Ahmedabad Ophthalmic Society. So welcome, Dr. Mohak. And that brings me to the first question, which was actually planned as a direct question to Dr. Gopala Raju, but nevertheless, I will take it up and I will answer my part and then over to the team. The first question is, how do you build patient loyalty through better communication? So what are the examples of communication in your eye hospital which enhances patient loyalty? If I had to answer that, I would say to inform patient if there is any delay in time of for the delay from the side of the doctor or some procedure or a machine not working, if you're able to advise the patient in advance, that's one very important factor, because time is something which is very important. Time of the patient, time of the attendance. But anybody else in the panel would like to take that question, I'll be very happy. How do you build patient loyalty through better communication?
I'll just say, ma'am, when I went to US for an observership, I asked the question, what are the chances of litigation? And they said, we never had litigation. It was very surprising. And the consultants with whom I have worked, I got the impression that if you have your insight intact and if you believe in what you are doing, chances of your patient having confidence is very high. So I think let's go down to your root and start doing what you believe in, and your failures will go lesser and lesser.
Excellent. That reminds me of this famous quote by Malcolm Gladwell. Malcolm Gladwell in his book Blink said that the first 3 minutes when the patient is in the doctor's chamber, they thin slice the doctor. They're actually examining you under the microscope and seeing whether you are making eye contact, you're too busy with your phone, you're, what are you in the first 3 minutes? So if you're really connected with your patient and you really mean well, then litigations will never happen. And that's what he also says. So Dr. Malai, you have somebody who agrees with you completely. Thank you so much. So that brings me to the direct question to Dr. Malai. What are the challenges in communication in the COVID era and how did you overcome it?
So can I do my screen share, ma'am?
Please do that.
Yeah. So thank you, Dr. Zamindar, for giving me this opportunity. And I thought I will be more ordinate if I make this slide presentation. Challenges in communication in the COVID era, especially this era. And the first thing which struck to my mind, and which I also failed when I was I also felt when I was communicating with the patients, is that you are doubly masked. And when you are doubly masked, actually it becomes very difficult to speak. So speech goes down. It is as you grow in your age, your cardiorespiratory reserves are also going down. So in the talking time, which we have been talking so much about during this IC, goes down and down. So what to do? One of the things which you can do is delinking examination with chatting. So what I do in my practice is, that we try to assess the patient before patient comes into your practice. And then suppose if I am doing a slit lamp examination, after the examination, I tell the patient these are my findings. And then we can go for an audio visual talk once we remove our mask, and then we can enhance the talking time. And that's how we have been able to chat better. So that is post-examination teletalking and pre-examination screening. These are the two tools I have adopted in my practice in the last couple of months. Now, I found that handouts are very useful, and I have created certain handouts in my practice. For example, this handout about the cataract surgery tells you in Hindi, motiyabind jitna kacha utna acha, softer the cataract, easier it is to operate. It is absolutely contrary to the contemporary beliefs that we want patient cataract to get mature and then take up the surgery. I have found it very difficult to explain to patient what are the earlier features of cataract, and I have developed this small paper for them. Then for retinal breaks, there are certain conditions about which patient is not knowing. They don't know the disease, they don't know the complaints, and they also don't know what is the fallout. It's the doctor who's worried about it. And so I made this slide for peripheral retinal breaks. And computer handling tips are so often given that it's better you tell them, please go and read. These are the 5 points. If you read, you're happier. Likewise, I would like to say that you have to be proactive in the communication. See, the problem is when the patient comes, sometimes their questions are very apt. Sometimes they actually create confusion. So if you are proactive in communication, then probably you will be taking the lead and you prepare facts. And how do you prepare facts? Frequently asked questions. So whatever question comes has been asked by the patient, write down on the Excel sheet, take top 10. And then you are actually covering 90% of queries. 100% is not possible. Select cost-effective measures. See what happens. We are under economic crunch, and that we have to realize. We don't have to say that we are very rich. So what I'm doing, I'm taking my instrument printout and I convert into an office printout, and we give printouts. So once we are giving printouts, the thing becomes very cost-effective and very easy. I give you one example, and that's my last slide. How to counsel for a prophylactic PI. That I found was very, very difficult to say. You are concerned that patient's end chamber is shallow. Patient does not understand what is anterior chamber. So I have made this slide for that. So I tell my patient what is the front part of the eye. I tell them what is a normal anterior chamber. How does a shallow anterior chamber look like? If you don't treat, patient will land over into acute congestive glaucoma, and what will happen if your eye becomes like this? This is your anterior chamber looks like. For the patient, for a normal person, these photographs are all Greek and Latin. But once you tell them and show them, it really improves your communication. And tell about this is a laser. That's how your eye will look like after a laser. And this is a small handout which is answering the frequently asked questions related to the PI. Thank you, ma'am, for giving me the opportunity. I would like to take up questions.
That was really interesting, Dr. Mala. You brought in some very new and innovative means of tackling this situation. Does anybody have a question for Dr. Mala?
I would like to add something.
Yes, go ahead.
It was very informative talk by Dr. Malay. So one thing which sir very correctly pointed out, that since we have a mask on, it becomes very difficult for us to communicate. And in such cases, like I have a personal experience, I work in a charity hospital. So in that time, we see around 40 to 50 retina patients in a day. So one suggestion which I have is usually that when the patient comes, try to first listen to the patient. Okay, so instead of me asking the patient what problem you are having, I just wait patiently and let the patient begin. Okay, so many times what happened, the patient comes, he must be having a, say, an inferior RD or something, but his complaint will be like, I'm having itching, watering, just because his macula is on, his vision is 6/6. So I know where I have to concentrate. Though I need to tell him that he does have an RD, but starting everything and asking him, then he giving me one by one answer to each of my questions, that increases my time. It increases my effort to talk, which is wasting my time, wasting my patient's time, etc. So minimum words you can use to counsel the patient if you exactly know what the patient has come to you. That is one thing. Second thing which I feel would help, like when the patient comes, let's keep yourself in the patient's position. Like when a patient comes and I have to explain to him that he's got an RD. So I think we should find out very simple ways to explain the patient, like how Dr. Malay said that in the last, he made that chart to explain PI to the patient. So what I do at a patient who comes with an RD, I just tell him, आपके पर्दे में एक छेद है जिसके वजह से पर्दे के नीचे पानी इकट्ठा हो गया है और वो निकाल के हमको पर्दा जगह पे बिठाना पड़ेगा. So I talk in a very basic language which the patient understands. No technical terms, no RD, FD, no need to explain the retina, everything. So that minimizes my effort and the patient understands. So he has no further queries. He said, हाँ डॉक्टर साहब आप जो ठीक समझे कर दीजिए, बस मेरा पर्दा चिपका दीजिए. So that's how, like, if you come down to the patient's level, so it's becomes very easy to connect with him. So that is one suggestion which I had on this point.
Just like to take 60 seconds of this, ma'am. I'm sorry, Dr. Malay, I cut you through. I was just trying to shape up my response to your first question. How do you ensure patient loyalty? And I would just like to differ from what Dr. Sarvesh has just spoken. So what I do is, how do you ensure patient loyalty is by winning trust. It's very simple. We have to win their trust. And how do you win their trust? Is by ensuring that you deliver what you promise. By acting or working at a certain level, we all work at the same level and we all deliver. There's no question about that. We all deliver. The discrepancy happens in what you promise. So you must make sure what you promise is not exceeding what you deliver. So that has to be kept right at the comparative level. The other thing that I have found out working for me at least is, since you mentioned that I'm a tech savvy consultant, I take a lot of pride in that. And believe me, when you talk to the patients and take your discussions to a certain technical level, they do understand. You were surprised to know this, that I get a vivid amount of success by talking to patients, even understand the importance of angle alpha and modulation transfer function curves in not choosing a multifocal IOLs for them, because they're very, very educated nowadays. And even if they're not, they go back home and find out about it. So they have to understand that you're offering something extra, something specific that they're not getting at other places, which ensures they're keeping on coming back to you further.
So I would like to comment on that what Dr. Anurag Mishra has said is a very fantastic suggestion that really works on for very well-educated patients. But you have patients when you are coming from villages and all, so there you have to modify yourself according to their needs. So I agree with you when you're counseling for multifocal and toric lenses and all, but when you have CAM patients around who are having a mature cataract with an RD and all they're interested is to get rid of the cataract, then how do you come down to their level to explain you have an RD along with a MatCat? So things are a bit different. It's not as simple as just getting rid of the cataract. So what is my suggestion is modulate your frequency.
Have the flexibility.
Flexibility.
You should be malleable to fit into all circumstances.
True. Very true.
You need to customize according to each and every patient that is sitting in front of you. Absolutely. One more thing I would just like to highlight. Other than that, the speech, the difficulty in speaking to and making the patient understand with the double mask. Another problem that we face is to limit the number of attendants in our clinics. Because during COVID time, we don't want many attendants with the patients. So the role of the paramedical staff, it increases a lot. Because right from the gate where they are helping them sanitize their hands, taking temperatures to the reception, they need to tell each and every step that only one person should go inside. The person who can understand or who is going to take care of the patient should be with the patient and things like that. So that makes the doctor's job a little bit easy to make the patient or the attendant understand a bit easy. So patient comes to us, after that we have to handle him. But before he comes to us, if he's primed, if he's conditioned, then it the job becomes slightly easier for us also.
So you're right, Dr. Vibhuti, and we have found a solution to that, that how do you reach out to the attendants? Attendants are mainly made to sit outside our hospital in the open waiting area, but our doctor invariably picks up the phone and connects to the attender and talks to the attender if they've seen an elderly person or maybe, you know, a child and the parent is outside, which is very rare. But if in any which case, if there is an attender and the attender wants to know what happened to the patient, the doctor is definitely talking on the phone. So that is what we did in the COVID times, and with great gratification that we were able to practice that part of our work also. So thank you so much. And we now come to the direct question for Dr. Sarvesh Tiwari. Have you found some tips for effective communication, something which has worked with you?
Yeah. See, as most of the talks have already given us fantastic points and they've already covered most of the things. The things which we have not discussed, I'd like just to give you a few examples for that. The things which I usually practice in my day-to-day practice. Since I'm a VR surgeon and I don't do cataract surgeries, to be specific. So one thing which I always have a little bit glitch and a slight complaint against cataract surgeons is they always tell the patient that you have a cataract and we'll do a fantastic surgery. It's a 15 minutes job, nothing to worry about. You'll get 6/6 vision the next day. I know as a VR surgeon, I'm not sailing in the same boat as they are, but I feel that somewhere you are underrating your effort. According to me, a cataract surgery is not as simple as we say to the patient. We are operating on a patient who's seeing. Okay, as you said, somebody said that a immature cataract, as Dr. Malay said, immature cataract is the best cataract. So this patient might be 6'9", and you take him up for surgery and something happens and the patient lands with 6'18", he's going to sit on your head. So technically speaking, a cataract surgery is more difficult than an RD surgery because a detachment patient is not seeing, a cataract person is seeing. So I always tell my cataract colleagues, don't underestimate your effort. Don't make it sound like as if the patient has come for a haircut to you. No, it's not a haircut. It's a cataract surgery. It involves a lot of skill, and make the patient understand that it's a cataract surgery. Things can get wrong, though the chances of it happening in your hands is absolutely less because you have experience of so many years. So that is one thing. Second thing, what I said what I feel that coming back to my previous point, use simple words to explain the patient. Like say, God forbid, a patient lands up with an endophthalmitis, say 1 week post-operative. So my suggestion is when you see this patient, as a VR consultant, we never use the word ki aankh mein infection ho gaya. Never. What we say, aankh mein sujan aa gayi hai. Okay? Even my suggestion is when you're putting it on paper, put it as post-op uveitis. Okay, endophthalmitis is a post-op uveitis, which is infective in nature. So technically, what is why you have to be politically correct. Okay, you have to be technically correct, but use the right words, because the moment you use infection, the patient will start panicking. So don't use those words. Same way in our detachment cases, if the patient lands up with a redetachment, we never use the word ki your retina is redetached. We will not say aapka parda dobara sarak gaya. What we use ki aapke parde ke niche pani ikattha ho gaya hai. Okay, so technically we are correct. So the patient doesn't get alarmed. So these are simple tricks which have over the years I've realized the patient is ready to go for a resurgery, saying that what the doctor is going to do is just going to drain off the fluid. So if I use ki parda dobara sarak gaya, he said you didn't operate well and he'll sit on my head. So these are the simple terms which you can use to save your back in case of you land up in such a situation. Another tip which I will give is, if possible, always talk in a vernacular language to the patient, if you can, because you get an instant connect. If you have a very well command on the vernacular language, the patient connects with you instantly. Okay, because all said and done, if you talk in a different language, many times the patient, there might be some degree of communication gap between you and the patient, which gets totally ruled out if you're talking in the patient's language. Another point, like when you have two patients of complication, this most of us are already aware. Don't ever call them at the same time. Okay, like suppose you have two patients will land up with an endophthalmitis the same day. Make sure they don't come together. Okay, so that all said and done, they should not communicate with each other. So these are the way of which we usually put it in our practice, and these are simple small tips which I can now give. Any other inputs from other speakers is welcome, sir.
I learned a thing or two from you, Dr. Tiwari. Thank you so much. Anybody has something? I'm going to take the cataract work very seriously, and I'm going to do this. But yes, anybody else would like to add something on?
Just, I think one point.
Yes.
I never tell my patients that cataract surgery outcomes are 100%. Because the thing is, as you have told, the surgical outcomes are not under your control.
Correct.
They are multifactorial. And whenever a patient asks, one of the presentations, when I was preparing my presentation for this talk, one thing which came to my mind, the dirtiest question that the patient asked is, "Sab theek ho jayega?" And whenever the patient asked this question, I said, this is in the hands of God. Put it to the God. Once you put the things on God, you are relaxed. Things become very easy. So that's my take.
Absolutely. I think the only communication which the patient should understand is that this doctor who I am consulting is not going to leave any stone unturned for my treatment.
Yes.
I'm not God. And he's not God. Definitely, Dr. Mala, you're right. We are not God, and the patient should understand that, but should also understand that ye mere liye sab kuch karenge, puri koshish karenge.
Yes. So the difference between the first part of the presentation and the second part of the discussion is that on one hand, you're talking about empathy and trying to develop something in you. On the other hand, we were discussing about practice management. Practice management is more of a trick, and developing empathy is more of a skill development. So I think the first part has its own points, and you also have your own points. And we have to make a mix and match.
Correct.
Empathy is a skill development. Empathy is your own spiritual journey also. So you're right, Dr. Malay. I would agree with you. That brings me to the direct question to Dr. Vibhuti Bhushan. Dr. Vibhuti, you have actually shared with me a lot of things which were your thoughts about involving patient as a part of the quality assurance team, because you talk about quality and improvement, but the most important person is missing. So what are your thoughts about it? What should we learn? How can we involve patient as a part of the quality assurance team for bettering communication or bettering anything in your organization?
Yeah, true. Actually, patients, once we treat them, they become the biggest ambassadors of our skills. So they bring more patients. That's there. It is a universal truth. But then they have a lot of potentials for adding a significant dimension to complete the quality improvement, actually. And whenever the patients feel that they are being listened to and their feedback is important, it can help our practice improve patient engagement, and that is the key to improvement and retention of patients also. The healthcare system in our hospital, it consists of small microsystems, clinical microsystems. Every touch point is a microsystem, we can call. Right from the reception to the workup area where the optometrist interacts with the patient. Then again, patients come and sits in the waiting area. Then he comes to the doctor. Then the doctor explains, but invariably that patient will again go back to the reception or catch hold of some person to again request them to re-explain everything. So all these areas are touch points. They are microsystems. So we need to take care of all these areas and get a feedback from the patient, which areas he feels needs improvement. And there are various ways of doing that. Actually, the reasons why we should do it, that because we need to track the patient's journey. Once he enters the clinic and goes through the whole process, where all he had problems, we need to collect data about the patient's loyalty also, that how many patients we are retaining, how many new patients are patients we are able to retain, and any ill treatment from the staff members. Actually, there are mainly three reasons why the patients complain and why litigations occur. Number one is if the treatment, something goes wrong with the treatment, or there is some problem with the behavior of the doctor or any staff of the hospital. And the third thing that and two more things that the patients feel very important is, one is whether he was attended in time or not. The time that he was given, whether at that time he was called or he was attended or not. And then the hygiene of the hospital. These four things, actually, they talk outside a lot about these things. Hygiene, the moment the patient enters the hospital, he looks at it and creates a general impression about him, about that whole setup. Toilet ganda hai, yahan pe ye ganda hai, the dustbin is not there, the papers are thrown, littered, and things like that. And the staff is not wearing proper uniforms, shabby looking reception. And it gives, first impression is a very important impression. So all these data, all these touch points, whatever experience the patients have on all these touch points, we need to gather these data. And we can engage the patients on individual levels, in group levels, in organization, and on a social level also. We can connect with them through emails. We can give them notes in our clinic. We can give them feedback forms to fill, and we can call and ask also. I used to do all these things. I used to give feedback forms. I had a complaint box also, not exactly complaint box. I had written suggestion box, so that if you have some problem, then you please give us some suggestions also how we can overcome these problems. But I received a few papers in which they had specifically mentioned that we cannot write everything. So it is better if we talk to you, if we talk to the authority, if you talk to the HR team one-on-one, and then we'll be able to help you. And those patients were my old loyal patients. They genuinely wanted the system to improve. They genuinely wanted some things to improve in my setup. So I planned that, and we have our meetings. So I'm yet to start that because of this COVID. I was not able to do that. But I think that's a brilliant idea. When we have our monthly meeting or fortnightly meeting, we can call a couple of patients who had that kind of feedback, who had given that kind of feedback, to really talk to them, and they'll be free. Generally, they don't want to write anything because they feel that their treatment might be affected if they get identified that they had this problem. So not doctors, but the other areas, they might have some problem in that center also. So that is why they wanted to talk to HR team or the doctor directly. So I'm yet to implement that, but I think that I'll be doing it very soon. And other things, as I've mentioned, we can include patients, include in the questions that whether he got some conflicting information from different doctors, different places in the hospitals. At times, what happens is, out of excitement, the optometrist commits something, he tells something, then the patient is confused, he comes to us, we tell something, there is a difference of opinion, and then the patients get confused. They don't feel, at times, some of them, they come out of the chamber and they get confused. They don't know whom to believe more. Whatever doctor is saying, ultimately that is the bottom line. But because the optometrist has said something, or some staff has said something, some casual remarks they have made, so that kind of thing. In a hospital where many doctors are sitting, maybe he has been attended by some other doctor on some other day, and so that kind of uniformity has to be there. Some guidelines need to be given absolutely straight guidelines to the paramedical staff that this is your limitation. You cannot say this, whatever, no matter how the patient is behaving or how much he is insisting, you cannot commit this, you cannot say this. So for area wise, your reception people can tell this much, optometrist can tell this much. So this is something that is a part of a training that needs to be regularly updated. And so that will create a situation where the patient will not have contradictory statements, contradictory things from different people in the same hospital. So that will reduce a lot of confusion. And most of the time, 80% of doctors, there have been a few surveys, 80% of the doctors believe that we are attending the patients in time. But only 30 to 40% patients accept this fact that they were attended on time. With Us problem is that there is a lot of time goes into initial workup also. When we tell the patient that their appointment is at 10 o'clock, they come with this mindset that at 10 o'clock I'm going to sit in front of the doctor. That doesn't happen. 10 o'clock he comes, he gets registered, he goes for a workup. Maybe if he is dilated there, maybe in half an hour time, 45 minutes later, he will come to the doctor's chamber. So these things need to be explained clearly to the patient while giving appointment. And patients also understand, over a period of time, they understand the system of that hospital. But these are a few points which they need to be, which needs to be clarified so that the patient don't have this confusion. I believe all of you are doing this thing, feedback, you are taking feedback, you are giving handouts, you are taking suggestions from the patients. But physically calling a patient in a meeting is, I think, is going to help a lot, and it's really a good idea to do. I'm yet to start that, but I'm sure that's going to help my practice also.
I think you've made a very nice point, Dr. Vibhuti. I think the patients have to realize that the credibility of the feedback form they're filling is proper. They have to realize that this piece of paper is going to be an asset for the hospital and it's not going to land up in the trash can. And how would they realize that is because is when there is a call back from the hospital to inform them that this is what you had written. And I do that. I have done that. I just cite you an example. The feedback can come as little or as surreal as some patient had written that there was a waterlogging in the bathroom and my mother almost slipped. That was the feedback from the patient. So there was a call back from the hospital, letting him know that the problem has been sorted. The bathroom's dry now. And the next time you come in as the attendant, we'll put you in the same room and we will ensure that the patient or the elderly whom you're accompanying is not slipping. So the patient also understands that there would be a next time. So the patient would come back to at least check the feedback that he had given has been worked on or not. So very nice point made by you. Absolutely agree with you.
If we go to some other hospital as a patient, and if this kind of response comes from that doctor, from that hospital, we feel good. So definitely any patient is going to feel absolutely elated, and we will definitely have a very good impression about that setup.
Right.
So really nice, and the action taken on the feedback given by the patient should also have a time limit. You should say that, okay, we said that within 48 hours, so say within 72 hours we will do this. Action taken, feedback should be given to the patient within a time frame, and that you can decide according to what you want to do, but that is also very important.
I have a dedicated staff for the purpose, ma'am. My counselor does it because outside the hospital hours, she doesn't have any work. So she is the one who takes up this thing on an urgency to get back to the patient personally.
That's really nice. Thank you. And that brings me to the direct question to Dr. Mohak Shah. I'm enjoying doing this. I think I should do this more often. Innovation in communication. What are the few things? And I think you have another 4-5 minutes in interest of time. Quickly tell us what all new things you're doing at Cure Specs in Ahmedabad.
Yes, ma'am. Sure. First of all, I'd like to congratulate you and your team for putting up this fantastic IC. I think all the points are spot on. But the one thing I would like to disagree, that ophthalmic surgery patients are not elderly. Being a dominant refractive surgeon, we do get a lot of young patients. And these technological era, there are a lot of Google savvy, tech savvy patients. And personally, being a young doctor, I know what they are thinking exactly. So I'll give you one example. Nowadays in refractive surgery, the smile surgery, DLEX smile surgery is the latest one right now. But it's a very costly surgery. One surgery for both the eyes, it costs around 1.2 to 1.3 lakh. So it's a very difficult. Patients also don't know, because even where I'm practicing at Ahmedabad, only we have this smile surgery, not the other surgeons. So it's difficult to promote this surgery. So what we did, we had made the special dress codes for the staff, where they had, special QR codes written. Smile, ask us what is smile. So patients, when comes, they just scan these QR codes, and specifically the points which are made by me and my team are, just open into the browser and just browse through it. So ultimately, when they come to me, and at our clinic, we don't have the counselors. Only the doctor communicates finally with the patients, and we counsel personally to all the patients. So when they come to me, you are very well much informed about the particular procedures. Like that, also the ICL surgery is picking up very well. So another staff is wearing a QR code. What is ICL surgery? Please know whether your eyes are eligible to undergo that or not. Another important thing, like you have those stamps, like these are the steroid drops, and you need to put those cautiously. For the patients, what we have done, we have made these specific stamps. Suppose one patient is having very high numbers, like patient is having -8 numbers of myopia. So those patients are always at risk of developing the regression or night vision and glare problems. So we do explain them specifically. And what we do, we have this stamp and we have them and the relator and the relative sign over it. So it's also one type of legal safe to me. So these are the two things which I have done innovatively, and it has really helped me well. And the third thing, we do, that we never hide. If there is any complication, we never hide from our patients. I will tell you the one example. Just day before yesterday, we had done the super basic surgery. We had put the bandage contact lens over the flap, but while removing the bandage contact lens, by mistake, I slipped, and one of the patient's flap got displaced. And the patient was himself a doctor, so he understood that there was a watering and everything. He asked me what happened. I clearly told him, I have by mistake displaced the flap. I'm going to correct it, and we even show the surgery live. So ultimately, the patient's relative, they were quite happy with our approach, that we did not lie to them. So similarly, if you have the infection, you should tell the patient that you have the infection. You should not lie to them you have the Sujan or whatever that, because ultimately they will go to another place. They are going to find out that you have the infection, but your doctor, the previous doctor who has treated you, is lying. So that is the last thing you'd like to do. So be always truthful to your patients, and you can have all these tech-savvy ideas, because nowadays, everything is Google dependent. So this is what we have done. I don't know what others have done. I would like to have quick inputs from others too. Thank you.
Yeah, this is something very, I would like everybody to sort of share what they have done, what new innovations they're doing in their practice in general and in communication. And then I come to the last question, and the most important question, to Dr. Anurag Mishra. So please think about it till Dr. Anurag answers his direct question. How does a leader help set the culture for better communication in a hospital? As a leader, what is your role to ensure that there is better communication in your hospital?
Well, the relationship between the leader and the led is a very delicate one. We have to understand that first. Communication obviously happens in two ways. One is verbal, the other is non-verbal. When it comes to me communicating with my team, the led and the leader, it is 10% verbal, 90% non-verbal. I'll explain it to you how. The only time when there is a free exchange of words across the table between me and my team happens in the weekly meetings. We have a meeting every week, and that's the only place where we talk freely. Apart from that, the 90%, the other communication that happens right throughout the working hours in the hospital is non-verbal. We essentially focus at four things in the non-verbal communication segment. First, punctuality. Now, no leader wants to be back answered by his team. I would definitely not like my subordinate to answer back to me, right? If I don't like my subordinate to answer back to me, it is better that I don't put a question across. Punctuality. Why would I ask my assistant to come in time? Why would I do that? What I need to do is me presenting at the hospital in time, and should the assistant come late, just one glare at the assistant and one glare at the clock will do the job for me. I don't need to speak a word. The next time the assistant will not come late. So that's punctuality. Sincerity comes from fellow feeling towards the institute, towards the organization. We ask our team to write contents for Facebook, Insta, YouTube. I just put it up in the group that I need something to be put up in my hospital to promote the vaccination drive against COVID-19. They work as a team. I don't even know. We know that who has done what, but they don't come out with it. They work as a team. They put up pamphlets, they put up posters, they put up models, they put up kiosks, all homemade, all made with their own hands. And it was beautiful. It was done within 48 hours. All of them got into it. So that's sincerity. Third is focus. It's a strict instruction. No assistant is supposed to get up and greet either me, the admins, or the other superordinate staff in the hospital while they're working. If they're scanning a patient, they should sit down and continue scanning. If they're refracting a patient, they should sit down and keep on refracting. Nobody is allowed to turn his or her head and greet the superior staff which has come in. In the OT, it is absolute strict as an instruction. No words spoken in front of the patient. Everything happens with sign language. the cross-check of ILPAR, the eye to be operated, the BSS bag being changed in the machine, everything happens with silent notifications. No words spoken in front of the patient. The patient does not hear a thing that goes on the OT. We have music played. I'm a music savvy person. Music's there all around my hospital. And the only thing the patient gets to listen to is music that's streaming from the system and not words. The final thing is mistakes. Should an assistant commit a mistake, how should you take it? Not with words, not with strong words, not with humiliation, not with shouts when others are around. The only thing that I get to tell them is when they're alone, I call them up or call to the office and then say that should there be your family, your relative in the patient's place, what you did, how would you extrapolate and how would you feel? One word like that and the mistake gets rectified there. Needless to mention, if you do not depend on verbal communication and your non-verbal communication is 90% of your communication, your words act like trophies. We do declare employee of the month every month, but even without that, if somebody has done a good thing and the leader who does not speak a word normally calls that assistant to his office and says a job well done is a trophy, you don't need to give anything in cash or kind, that thumbs up is prize enough for them and they get motivated to work more. So that's the importance of non-verbal communication. I'll keep it at that.
That was amazing. I just love this concept, which matches the concept of IKEA, which we also follow at our center, that there are no subordinates. They're only co-workers. We all work together. That's it. So besides this, any other bright ideas about innovative practices? Yes, anybody?
Just one thing I wanted to just add. We need to create an environment in the working in our clinics where the subordinates or co-workers, they feel like coming and working. They are not stressed. So most of them are not from well-to-do families. Many of them are from a very lower middle class family. So they might be having a lot of troubles in their own social circle and things. So this thing, we must be very compassionate and very, sympathetic about this, that we should create an environment where they feel good when in the morning they have to come to the hospital, they are happy coming to the hospital and working there. So that kind of an environment, if you are able to create, it's a job there.
That's a huge achievement, Dr. Bhushan. I completely agree with you. I would want Dr. Katyani, Dr. Nazia, and Dr. Samia to please on their videos, and we can take a quick picture before Sabrina asks us to move out. Yeah,
You must be itching to do that, ma'am.
Thank you so much.
I must say that this was a fantastic IC, and we have learned. I have learned a lot.
That makes two of us. Thank you so much.
All of us have gained so much from these. Yeah.
Fantastic. Yeah. Great.
Thank you so much. Take very good care of yourself. Thank you again, everybody.
Ma'am, before we dissociate from each other, we'd just request you to take it to national platform and organize a well-formed webinar on this. I think this would be catching a lot of attention all across the country.
Definitely. We would like to do that, and we would like all your support to see that this happens.
Always there, ma'am.
Right?
Always there, ma'am.
Take care.
Okay, thank you, Dr. Samina, for inviting us.
Thank you, ma'am.
Thank you.
Thank you,
Have a nice day.
Thank you.
For all the hard works in the great session. Thanking you all to be a part of the 79th AIOC virtual conference. We now conclude this hall. Thank you.
Thank you.
Take care.